Hello everyone, this is Matthew, and today we're going to talk about heart valve repair. So if we look at the data, heart valve repair has been increasing in numbers when compared to heart valve replacement. So from 2000 to 2007, that increase was 51% to 69% rate of mitral valve repair, where mitral valve repair is the most common form of heart repair operated on. The operative mortality was about 1.2%. And then if we look at tricuspid valve repair, which is not very common, it's still not very common today, from 2004 to 2013, there was 5,005 isolated tricuspid valve operations total in the United States, with an increase of 290 in 2004 and 780 in 2013. So like I said, the TV repair is not very common and its mortality rate is 8.8%. So if we look at the risk factors, they're more related to preoperative factors that could potentially lead to another repair later on in life or even death later on. If we look at the factors here, we have poor ejection fraction, history of stroke, unstable angina, or implementation of a cardioverter defibrillator, which helps stop dangerous cardiac arrhythmias. So like I said, if we have any one of these, there's a potential that the patient could come back and their heart valve failed again and they would have to get another repair or potential replacement, or even they could have their predictions of potential death later on after the operation. So why would someone come in for a heart valve repair? There's several different pathologies related to deformities in the heart that would indicate someone needing a heart valve repair. Mostly it's associated with valve regurgitation, but there's patterns in rheumatic heart disease and, like I said, anatomical abnormalities such as congenital deformations, stenosis present, or just general heart failure. So if we relate things to exercise tolerance, we're going to look at two studies. This first study compares mitral valve repair using a band versus a ring. So we have the repair of the band on the left side picture there, and then what we would use as a ring on the right side picture there. So for the study, there was 107 patients with a mitral valve repair. 65 had the band put in place, and then 42 had the ring. The subjects were to perform a 6-minute walk test with a short form 36 questionnaire performed afterwards. The results showed that the band group for the 6-minute walk test could walk 471 meters approximately, while the ring group could only do 443 meters approximately. The ring group also reported on the questionnaire lower levels of energy and general health. So if we have patients with different kind of mitral valve repair, band versus ring, we would expect that the band group would have a higher exercise tolerance than the ring group. So for this next study, we can compare performance of exercise before someone has a heart valve repair and after a heart valve repair. So for this study, there was 26 patients with mitral valve regurgitation, and they underwent exercise echocardiography and cardiopulmonary exercise. Some of the tests were performed a week before, and then there was 4 months after the repair was done, the tests were taken again. And after surgery, they showed improvements in peak oxygen uptake, peak oxygen pulse, and maximal workload. So as physical therapists, what are we going to do? We should run through the cardiac exam to make sure that this patient's heart health is working properly. So if we start at the targeted history, we want to keep in mind those preoperative risk factors that we mentioned before, because we want to make sure there isn't any potential need for another repair in the future. We also want to look at any social factors such as drinking or smoking that may damage or increase the potential for heart disease, or if we want to see if there's any other surgeries besides the heart repair that was present, or if there's any current heart problems that we should be aware of. If we observe the patient, we should probably see some scarring due to any surgical operation, especially in a more invasive valve repair. We also want to keep in mind their general appearance, such as their work of breath and facial expressions. If we check their vital signs, we want to obviously keep in mind their heart rate, pulse, and blood pressure, which we will continue to monitor throughout exercise. If there's an EKG present, we want to make sure there's no arrhythmias present due to an adaptation to the new valve. When we palpate, we will palpate around the sternum and want to make sure that nothing is popping or clicking, especially due to a chance of that in surgical damage. When we auscultate, this might be the most important part, especially when we want to listen to the valves. We want to make sure the valves are working properly, especially after the surgery is present. So we want to listen for closure of the repaired valve. So if it's a mitral valve repair, we want to make sure to listen to that S1 sound very clearly. But we should also be careful of any S3 early diastolic or S4 late diastolic sounds, which could be indicative of increased other valve problems. So for our plan of care and potential precautions, we want to do some exercises focused mostly on endurance. We want to monitor their vitals and observe the patient throughout the exercise, especially since they're going to show potential increased fatigue and lack of endurance. We want to monitor the EKG if it's present for any arrhythmias, and if any arrhythmias are present, we should monitor and depend on what happens. If we need to reduce the exercise, stop their exercise, and in that case, we want to retake their vitals or potentially send them out in an emergency situation to the hospital. Goals for this patient revolve around short term would probably be related to tolerance of high endurance exercise, to progressively increased amounts such as in treadmills or ellipticals. And a long-term goal would be for their ability to perform everyday activities, hobbies, or sports with a decreased exertion level.